All right, now, better, nothing up on the board. What you just saw was just a summary that I was showing a patient of just some basic ideas, some basic bullet points so that he understood what we were targeting, where we were going, how we were going to get there in terms that I think were very, very basic to him. You saw some smiley faces, you saw some sad faces. That was really based on what I thought he could do to have understanding on if what we were doing was still valuable to him. More importantly, as he added in some other things recreationally on his own, does that change what we're really after at a more fundamental level? And it's a really big explanation here. So what we're going to try and do is start from the beginning. And I think we did one of these earlier. It seemed like it was very, very well received. We're going to start off with the whiteboard. And I have an idea of how we can start to make this something a little bit more regular, where I will share everything that we have done so far. And this is not a very complex individual in terms of his issues and where he wants to go. We got a lot of stuff going on, so using a whiteboard or some kind of check mark system so you don't miss anything is very, very useful. So let's talk about this fellow. And if this goes over well and it's well received, what I can foresee is taking these case studies and then taking something like an intro here on the whiteboard, demonstrate the therapies, demonstrate whatever special exercises, and then come back to the whiteboard and talk about more of a fitness and a long-term approach. And if we can start to piece that out, please, I hope you're able to tell me if that's something that you would like to see. And it may not be my patients. If you give me enough information, we can case study some of these ideas for the people that you're working with, whether it's training or a more traditional painful musculoskeletal situation. So we can probably get as complex as we like, and obviously my skill set, including referring out to other skill sets, we'll just map it all out and just give you a window into how you can start to piece together what you do into this model, T equals R model, call it whatever. I'm just showing you what I do and how I'm thinking. So saw a gentleman come in, older fellow, it's all about golf. Yeah, because I don't deal with golfers, right? All about golf, a lot of things on board. This was a former Division I, significant Division I athlete, big time school, big time sport. So probably very high level athlete, even though he's a little bit older, and a lot of wear and tear, maybe from being inefficient in what he does in his golf swing, which is certainly going to become a part of this discussion, but just how he trained and what he does, et cetera, et cetera. He's a hard driver and just likes to do a lot of things, and maybe not always the best idea when in terms of consistent with his joint competency. All right, now, main thing that really was bugging him in terms of his golf was some medial epicondylosis. So we'll start with that, and we'll just here, that's one piece that, and he actually considered that his priority. He also had opposite side shoulder. So this side is the right-handed golfer, left shoulder. Had a MRI and just some stuff. It wasn't terribly alarming for someone that has done what he has done in sport and where he's at now in terms of his golf and recreation. Also, going back to the other side, right knee, okay? We looked at that. What he did not openly complain about, other than maybe putting it as a 4th out of 4, would have been the neck. But he was not able to describe it as a significant problem or injury. So looked at all that stuff. He had MRI the shoulder. It didn't scare me. I don't even remember, didn't even care, basically, MRI of the knee after the evaluation. So here's how we went after it. We just, evaluate folks like this. We all start at the same place, but then go in as many different directions as possible. But everyone starts, this is at the medical level because there's pain. We have no idea what is generating his pain other than obviously a message through the brain. We're always going to compartmentalize pain in three ways. Number one, is it medical? Is this referred from an organ? Is this some kind of insidious illness? This is why completely unacceptable to just assume that pain is what you feel is within your skill set or what you want it to be. Number two, how I would term orthopedic pain is probably not something that is going to respond well to conservative approach, or is a long-term chronic problem where there is frank tissue change. A torn meniscus that is not going to untear, I would consider orthopedic. Some of the long-term epicondylosis, some of the long-term tendinopathies, I would probably also consider orthopedic, because those things can also improve from more than conservative approaches in conjunction with therapy and active exercise. And then lastly, the pain can be categorized in a neuromuscular category, meaning a bunch of exercise and therapy and the pain goes away. It doesn't mean the pain wasn't real. It doesn't mean that the areas were not involved. It's probably something that doesn't need the potential to be adjunct with things like injections, etc., or certainly needs to be further imaged or consider a more aggressive approach. So that's why we're going to use an evaluation model that tells us or gives us a little bit of an elbow, a little bit of a push on whether the pain is in these categories where physical therapy or physical rehabilitation is going to be useful, or do we need to get him out of here right now? And how do we work together with some of those things? Because this individual had already seen a physician, probably not consistent with this thought process. However, the myopic suggestions actually do play a role here, which actually gave us more time for what we were doing to create solutions. All right, so when we looked at the Keene movement assessment, we're going to look at as many different positions as required to understand, can joints get in the right positions to absorb adaptive stress? Do joints hurt? Are joints stuck? Do they have limited motion no matter how you test it, taking out single and double joint muscles, different stabilization patterns, active versus passive? If it's the same all the time, it's a mobility issue. If it's not same all the time, joints are weird, that's probably a motor issue. And then of course, does the joint do everything you want it to do within the ranges that you would want to train the holy hell out of it? And now we can compartmentalize 4 different approaches based on this level of evaluation. I would be very condescending towards an evaluation model that does not look at every joint in the body and categorize the intervention that can improve that system. There's a whole group of things you would do for pain. There's a whole group of things you would do for mobility. There's a whole group of things you would do for motor control. And there's a whole group of things that you could do for fitness. And you can probably carry over the ones that live next to each other. There's going to be pain and mobility. There'll probably be pain and motor control. There may be combinations of mobility, motor control at the same joint. And of course, fitness and motor control can certainly live together. So let's move forward and let's see, what did this individual's body start to tell us at an evaluation model? Okay, let's look at his neck. His neck was not happy with rotation right and left. Flexion was happy. His chin was able to touch his chest with a uniform spinal curve, and extension was also limited and painful. Okay, so I start there simply because it was on his list, but the order here is not terribly significant. If you do think that there is an area that is extremely painful, probably don't start there, because if you exacerbate the pain because your movement testing had any local biomechanical tests that were provocative, then you might blow up the rest of your evaluation. You're not going to be able to get much when there's a lot of pain, even if it's in a distal segment. So at the end of the day, doesn't really matter without that factor in mind. I went with the neck because I'm starting to think, here's a fellow that has elbow on one side, shoulder on the other side, tall, a little bit dumped over. I'm not going to automatically assume stiffness through the thoracic, but then what's the neighbor? He did discuss the neck a little bit, so I chose to start there because if we did blow him up, at least we had opportunity to take the rest of the time. Let's treat the neck, and we have every reason to believe that if you treat the neck, you could/should impact thoracic, shoulder girdle, and then elbow. In this case, clearly, I don't know how often, unless Triple H drills you with a sledgehammer, elbow issues are neck and or shoulder issues in an overload pattern, okay? So we looked at the neck, same with the shoulder. Now, interesting, medial rotation extension was much worse than lateral rotation flexion. And that should tell us something, that the overall joint system, the ball and socket, maybe a little bit of the subacromial space, we shouldn't be that alarmed that this is a terribly arthritic or significantly compromised glenohumeral joint. The soft tissues around it, posterior capsule, very common, again, from maybe some training choices, maybe some deceleration issues from his sport when he was younger. Even golf, clearly deceleration is an enormous part of that. So we're starting to see, fairly typical pattern, a jacked up neck and posterior shoulder stiffness. Remember, medial rotation extension alone doesn't tell us that it's an internal rotation problem. But right now, just for the sake of communication and how I'd like you to think through your evaluation process at this beginning starting point, this is what we're after, okay? Now, thoracic, it wasn't like stuck, it wasn't like 5 degrees, 10 degrees, but it wasn't nearly what you would expect to see for someone that had pretty good elevation through the shoulder in this benign pattern. So thoracic is on the list because thoracic can go to the neck, thoracic can go to the shoulders, and then of course as you impact the shoulder, you should in theory long-term affect the elbow. Elbow, very classic, all pattern grip was painful. Elbow extension with wrist extension. So if we stretch the medial elbow, soft tissue, that was painful. All right. So we're not finding anything here that we're letting a cat out of the bag. Now let's talk about the elbow a little bit. He had been given a recommendation from a non-surgical physician that he should have shockwave at the elbow. I have no problem with that. I don't have one. I don't think I can turn over 15 grand in terms of, even though whether I have a strong feeling on that type of therapy or not, I don't think it's going to hurt somebody as long as they're not spending the rent money. So I said, if you want to do that, I'm all for it, because it should do something. But what we explained was, even though we only have the upper quarter thus far, I thought it was imperative to explain that no matter what, whether we do some soft tissue work, whether we do some more central stabilization that we think can affect the shoulder, that we think can affect the elbow. And in this case, I did not think that. The cat was out of the bag. He had some frank tissue changes, very significant pain. But no matter what we do, manual needles, scraping, whatever it might be, we're still going to have to impact these other systems. We're still going to have to impact the stabilization of the shoulders. We're still going to have to impact how the neck is moving, particularly if golf, which is very, very clear even early on in evaluation, that is the primary provocateur here in terms of generating this elbow pain. So there's some kind of swing characteristics. So we're talking about how do we treat this individual as a human being first? How do we get him to move without pain? But we do have to be cognizant for what he's doing for his training and then what he does for his sport, because golf is highly specific. And in this case, I'll call it a sport, even though it's just recreation for him. What we're going to do is consider it sport because there's a certain way that he is being coached or asking himself to move. And he's probably not doing that. Because if he was, then he's a really lousy coach, which of course is quite possible. More importantly, I think he's trying to do something that his body's not letting him do, and he's overloading segments. Because he didn't have a big fat divot. You know, he didn't really remember doing anything that like really would jam up in that chicken wing technique and really get after that medial elbow. So it's really a chronic thing. He asked about cortisone shot. My experience, cortisone shot in the tendon, bad idea, never really works. But shockwave or other things, they can't hurt. And they don't take any, like I don't care. If I never see him again because he's happy from that, then I'm very confident it'll come back and you know, but that's a whole nother issue on how people feel about working with others because they're afraid to lose business. That's really not typically, no, it's never in my thought process. You don't work with me, you don't want to work with me. Hell, had a call yesterday with an NFL superstar, and I'm not going to be surprised if he's not interested. There was just it was a pleasant conversation, but not typically one that leads to more. Not worried about it. You do your discovery call, you do your sales pitch, whatever, as ethically as possible. If this individual thinks that Shockwave is going to be his solution, I would tell him that it's a great local choice. It's a great myopic choice. And if we know it's myopic and put that into a full view, then it can only help us. It can only help. Now, moving forward, forward bending. He could get his almost wrists to the floor. He says he does a lot of yoga. But if you look at the uniform spinal curve, yes, he was getting lumbar flexion, but he wasn't getting a significant level from above maybe T7. It was basically the same little bit of kyphosis, but he was so long through the backside that he was able to get there. Not going to be our major problem here. Not going to learn a whole lot. Extension, rotation. They didn't really reveal like an alarm here. Now, what about that right knee? The right knee was definitely on board here. Right knee, painful. Right knee with the squat and significant dorsiflexion limitation at the rudimentary test. So now, like, do I think that dorsiflexion has a lot to do with his knee pain? Yes. Do I think that dorsiflexion probably has a role in his golf swing that is leading back to whatever this elbow? Yeah, probably. Do I also know that from a fitness approach, to take advantage of the humoral and hormonal effects, things that I always say, and if I always say, it's because these are main concepts. You can do this all differently than I do, but what we can't do differently is respect humoral and hormonal impacts to pain and the rehabilitation process. We can just deadlift because he's got a great hinge. We'll deal with whatever. We can coach with some tension as we mobilize the middle thoracic. He can get all his hinges and deadlifts for his lower body strength and or power if we get to that point. So we're going to put the knee, on the back bend as long as we don't provoke it. He bikes a lot, doesn't really bug his knee. Again, I don't remember if there was an MRI for the knee, but no. The knee is not his troubles. And of course, as he works with me and as he works with Brendan here at Coastal Fitness, that's something that he's going to work on. I am not going to begin my thought process as getting into where if there was only the dorsiflexion. Yes, we got to look at tibial rotation, even though full body rotation didn't really tell me to look there. He's got pain in his knee. We got to do a local biomechanical assessment. But right now, we have to prioritize, because I also asked him, what is the most important thing here? It's like elbow. It's like I can't grip, I can't do anything. I'm like, okay, so as long as we're clear on day one, these are the things that we're seeing. And it's not that something in his knee or his foot, navicular, cuboid, cuneiforms, you gotta get after all these things, is driving a direct link to the elbow pain. That's not the suggestion at all. What is the suggestion is that when you put it all together, maybe this gets better and then comes back, or it doesn't heal as quickly because of the mechanical or neuromuscular motor strategies that are being driven by a frank mobility issue at the talocrural joint. If you don't look at these things, I don't know that that's a complete process. you can see, I'm even telling you, I'm not even doing anything about it right now, in our thought process of day one. But we are going to now start to think of prioritization. We need to look local at the neck. We need to look local at the shoulder. We need to look local at the elbow. That's really where our big money is. And we should always, whenever you see neck, shoulder, and elbow, we absolutely should be considering the thoracic spine, which in his case was not painful. So if there's a way to have him walk out the door on day one, understanding that if we mobilize the thoracic spine, that's probably not going to change the chemical process at the elbow, but that's going to be our big money. That's going to be, when he's, right now I build away, what is he going to do when he's not with me? He's going to get after the thoracic and to whatever opportunity he has with Brendan to get after dorsiflexion. And then, of course, if it hurts, don't do it. I don't think this fellow moves so poorly that we can't find a very significant catalog of fitness very, very quickly. So that was really where we left it. We didn't do too much treatment. There was a lot of discussion, a lot of understanding, translating what the MRI said in terms of the shoulder, where it wasn't terribly alarming, but that's where we're going to get to. So he was keen. I did ask him to see a physician that I had a relationship with in New York City to do the shockwave, because that's where he was going anyway. And they also did a fenestration procedure, and his elbow was significantly better. However, before he went, we did some needling in the relevant area. So if this goes over with the audience, I will demonstrate how we would dry needle for this type of symptoms. We'll get the camera set up and we'll have a patient and blah, 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 put my little gloves on and blah. So I'm not ready to do all that yet. I want to see how this is responded to. But so treatment one was some soft tissue and some needles. Also the same side shoulder, not the shoulder that he had symptoms on, same side shoulder. And of course, there are referrals. I did not think there were referrals. I think this was a frank, if we're gonna, he had not had the MRI there yet. ECRB, whatever you want to say, is your that would be your lateral epicondylosis. So I don't know what the common tendons that are typically involved in medial, but I also don't think it matters at this point. We're not doing surgery. So moving forward, we treated the shoulder, we treated the elbow, and we put in some thoracic drills, basic thoracic drills that I know he'll be able to do in fitness, the basic package, and then I just leave it to Brendan to coach up. We do rib roll, okay, for the thoracic. Then we'll go to quadruped, lumbar locked, and then we go to twist and tilt. I don't know if anyone calls it something different. On one knee, twisting towards the phasic side. And then whatever different, if I was coaching them up, you'd probably see what you might think are some DNS cues, etc. The fact is, we're looking to engage the barrier. We're looking for the individual to know the difference between engaging the barrier and not engaging the barrier. And then ultimately they can do it on their own. And then we come back and retest. So that retest would be, for this gentleman, I don't expect it to impact his elbow. I do expect it to have some impact on reaching his arm behind his back, medial rotation extension, and I do expect it to have some impact on the cervical spine. So there's day one. That's what we did with this fellow that came in for elbow pain and had this host of things that he largely was aware of. I think some other relevant information, he was getting treatment, but they were just treating symptoms and it wasn't even working. So that puts me in an interesting situation, not one that I'm uncomfortable in, but I don't terribly relish it. I'm like, everything should work. It may not work right away. It may not work as fast as you want it, but it shouldn't just, yeah, you're gonna walk out feeling good and then you come back and then you tell them, yeah, it's pretty much no change. So yeah, I'm sure we see that quite a bit. And hopefully you're not that therapist or chiro that allows the patient to tell you where to treat them without some kind of understanding, because in this case, all we'd be doing was rubbing on his elbow or trying to stretch out his neck and shoulders, and it wouldn't really do much. So yeah, not the answer. And even if you are doing that, are you following it up with rehab exercises? He had no exercise program. He's just getting probably what might have been competent manual therapy, probably without the clear vision of the entire body and how all of these needs for manual therapy were being generated. So that's our day one. So moving forward, when we're at the whiteboard, we have this good opportunity. If you find this individual, often seen in the Crichton section of Mobile, Alabama, if you shine a light on it, sometimes he disappears. But if anybody's seen the leprechaun, say, yeah,